Next, so beta we have discussed ACE inhibitor, ARB, spironolactone, and dioxin. Next, beta blocker. So beta blocker is also important part, that is because it decreases the sympathetic activation, and metoprolol, bisoprolol, carvedilol. So remember, all the beta blockers are not used. Preferably we use carvedilol. We can use metoprolol and bisoprolol also in treatment of the heart failure. As a general rule, beta blockers are contraindicated in acute decompensated heart failure. So remember the two paradoxical situations. So beta blockers, they reduce the cardiac output. We all know that. And in heart failure, cardiac output is already low. So we cannot use beta blocker in acutely compensated heart failure, because heart failure patients have a decreased cardiac output. But as a result, decrease in the heart rate and cardiac contractility produced by beta blockers would be expected to produce more acute cardiac decompensation in patients with heart failure. So remember, in patients of very symptomatic heart failure, when patient is dyspneic, when cardiac output is significantly low, we cannot give beta blocker then, because that will cause further reduction in the cardiac output, that will cause further decrease in the peripheral perfusion. But beta blocker is used for other reason, because beta blockers decrease the sympathetic stimulation that induce the excess catecholamine effect, thus decrease the myocardial aortosis. So it has been found that heart failure compensatory mechanism is sympathetic stimulation. So body tries to cause sympathetic stimulation, and that will cause increased catecholamine effect, increased myocardial aortosis, that will cause remodeling of the heart. And beta blocker, by reducing this catecholamine overactivity, will prevent this myocardial aortosis, and that will cause decrease in the remodeling. Also, there is decreased renin release by inhibiting the JG cell beta 1 receptor, thus decreased aldosterone production and reducing salt water retention. So there is decreased renin release because beta 1 receptor causes increased renin release from the JG cells. Thus, ultimately renin, angiotensin, aldosterone, all system is decreased, and due to less aldosterone and angiotensin 2 activity, there is less cardiac remodeling. And also, due to decreased aldosterone effect, there is improved salt and water excretion, and there is decreased cardiac remodeling, decreased heart rate, so reduced oxygen demand, and carvedilol has some additional antioxidant effect and vasodilatory effect due to alpha blockade action. So commonly you remember that metoprolol, bisoprolol, carvedilol are used because of their some additional vasodilatory property in them. That's why beta blocker with additional vasodilatory action is preferred. So that's why not all beta blockers are preferred in heart failure treatment. We have to increase the peripheral perfusion to increase the so that blood supply is more to the other organs to meet their metabolic demand. So beta blockers, by decreasing the sympathetic stimulation, decreasing the angiotensin 2 effect, decreasing the aldosterone effect, they promote the salt and water retention, excretion, and also they prevent the cardiac remodeling. And due to the antioxidant effect and vasodilatory effect, carvedilol is preferred. Carvedilol, how they cause vasodilation? Because they have some additional alpha blocking action. So carvedilol actually non-selective beta blocker, alpha blockade plus beta 1 beta 2 blockade, and because of the antioxidant property, they reduce the oxidative stress which is present in the heart failure states. That's why carvedilol is the preferred beta blocker in the most of the heart failure patient, except in asthma or COPD patients, because it blocks the beta 2 receptor also, there is chance of bronchoconstriction in them. That's why except asthma, COPD patients, or when there is respiratory compromise, patients having dyspnea due to other reason, then carvedilol should not be given. Otherwise, it is a very good drug because of its additional antioxidant property. If there is asthma, COPD, then we can go to we can treat with bisoprolol or metoprolol. So this is the beta blocker. There is decreased cardiac contractility, but actually that is causing decreased peripheral perfusion. This is sympathetic activation, and that will cause further damage. Actually, sympathetic activation causes further damage by apoptosis, necrosis, fibrosis, hypertrophy. There is cardiac remodeling. Beta blockade will prevent that. Okay. So that's why beta blockers are very important drugs today of therapy, except in acute state, when beta blocker should not be used. After patient is stabilized, then we can use beta blocker. So remember, among the drugs so far discussed, ACE inhibitor or ARB, aldosterone antagonist, and beta blocker have mortality benefit. Dioxin and diuretic do not have mortality benefit. That means mortality effect benefit is seen only when we have some effect on the remodeling. Only salt and water retention, excretion, also only increasing the cardiac ionotropy will not give you much benefit. Whereas cardiac remodeling prevention, that as done by the beta blocker, ACE inhibitor, ARB, and aldosterone antagonist, that will improve the mortality. Adverse bronchoconstriction and also sudden withdrawal is not needed, is avoided, because there can be chance of sudden precipitation of the MI or angina. absolute contraction, severe bradycardia, pre-existing heart block or overt left ventricular failure, active peripheral vascular disease. So peripheral vascular disease also beta blocker is avoided, because peripheral vascular disease, if you use beta blocker, then it will cause the remaining adrenaline or adrenaline in our body will cause activation of the alpha receptor, which will cause vasoconstriction, and that will decrease the peripheral perfusion less further. That's why peripheral vascular disease is a contraindication of using beta blocker. Next, a very newer drugs we have not read it in before, natriuretic peptides. So the atria and the other tissue of mammals contain familiopeptides with natriuretic, diuretic, vasorelaxant and other properties. Natriuretic means that will promote the sodium excretion. They are also act as a diuretic. So that means they cause sodium as water excretion. They have some vasodilatory property, and this family includes three: ANP, BNP, and CNP, atrial, brain, and C-type natriuretic peptide. The peptides share a common 17 amino acid disulfide ring, and when they are released, when there is stretch in the atrium. So when there is heart failure, the heart size generally increased because there is remodeling of the heart, and that will lead, that tries to increase the blood supply to the other organs, but ultimately it fails. So plasma ANP BNP concentration increases in heart failure, and when there is atrial stretch, this ANP BNP level is increased, and the level is also increased in the heart failure, pulmonary aldosteronism, chronic renal failure, and also inappropriate ADH secretion syndrome. So NP-BNP induced natriuresis is due to both to an increase in the glomerular filtration rate as well as a decrease in the proximal tubular reabsorption. ANP-BNP also inhibits the release of the renin, aldosterone and AVP, increase sodium and water restriction. ANP-BNP causes vasodilation and decreases arterial blood pressure. So ANP-BNP causes natriuresis, and this will increase the GFR, and also there is less sodium absorption. BNP also inhibits the release of renin, aldosterone and AVP, that is arginine vasopressin, increase sodium and water excretion. NP-BNP level causes vasodilation and decrease in the arterial blood pressure. So due to this excess sodium and water excretion, it will cause less atrial stretch, and ultimately, if heart failure treatment is successful, then BNP level is also decreased. So BNP acts as a both therapeutic as well as diagnostic role here. So in heart failure, BNP level is enhanced. Also, if BNP level is enhanced, that will actually helpful by causing atrial by causing salt and water excretion, and ANP-BNP by causing vasodilation, they will also help in increasing the peripheral perfusion of the other organs. BNP is synthesized primarily in the heart, and it exhibits natriuretic, diuretic, and hypotensive activities similar to ANP. CNP consists of 22 amino acids, and CNP is mainly concentrated in the central nervous system. And this, what is the clinical role? So natriuretic peptides may be administered as a recombinant ANP or BNP. So recombinant ANP BNP was synthesized but not popular because it can cause significant hypotension, necessitide carperitide. These peptides produce vasodilation, natriuresis, and inhibition of the renin-angiotensin system. So BNP also stimulates, inhibits the renin-angiotensin system, and appeared very promising for the treatment of the congestive heart failure, but clinical studies have produced variable effects. So remember, though ANP, BNP are released in heart failure during when atrium is stretched, but its effect is very short lasting, and that's why we try to increase the BNP level by inhibiting its metabolism, and or by some giving some producing some molecule which will have BNP like effect but will not degrade so quickly. Now BNP is metabolized by, or NP-BNP metabolized by two enzymes or degraded by two enzymes, that is called neprilysin and NC inhibitors. So vasopeptidase inhibitors inhibits two metabolic protease enzymes like neprilysin and NCE. So SE inhibitors also decrease the BNP, and neprilysin also decrease the BNP. So to increase the effect of the neprilysin, to increase the effect of BNP, we have to give some neprilysin inhibitors so that their effect is enhanced. So that's why SE inhibitor can have some effect. So SE inhibitor can increase the BNP effect because angiotensin converting enzyme inhibit the metabolism of the BNP. That's why SE inhibitor can help but neprilysin inhibitor, if we can give also, then that will cause further increase in the BNP effect, and that will promote the salt and water retention excretion, and will promote vasodilation to improve the peripheral perfusion. Thus, they simultaneously increase the levels of natriuretic peptides and decrease the formation of the angiotensin 2. So, if we can block angiotensin 2 production as well as block the or increase the BNP activity, then heart failure treatment is more successful. So recently approved vasodilation inhibitors are emapatrelate, somapatrelate, and fasitoprelate, but these are not now commonly used now. Sacubitril is a specific inhibitor of the neprilysin. So sacubitril is commonly used nowadays because it is specific inhibitor of neprilysin. Previously, this omapatrelate, somapatrelate, fasitoprelate are inhibitor of both neprilysin as well as AC inhibitor, and this has one disadvantage is that if AC inhibitor is used, if these are used omapatrelate, somapatrelate, there is significant vasodilation due to both ANP effect as well as decreased angiotensin 2 effect, as well as there is increased bradykinin effect because of the AC inhibition there, and there is significant vasodilation, significant risk of angioedema. That's why they are not popular. But sacubitril, that is specific neprilysin inhibitor, that is causing increased BNP effect but no effect increase in the bradykinin effect. That's why it is preferred. So less chance of developing angioedema than omapatrelate, combined with angiotensin receptor blocker for treatment of the congestive heart failure. So remember, AC inhibitor and if AC angiotensin converting enzyme as well as neprilysin both are inhibited together, there is far more chance of adverse effect because that will cause more angioedema, that will cause more hypotension because of the excess vasodilation bradykinin effect. But AC inhibitor জায়গা যদি আমি if you use ARB, then this excess risk of bradykinin effect that is not there. That's why there is less chance of angioedema, less chance of the hypotension or cough, and less chance of less chance of the deterioration of the patient. That means due to less risk of the angioedema, less risk of the hypotension, ARB is combined with the neprilysin inhibitor. That means sacubitril is combined with some ARB, that is example valsartan. So remember this, AC inhibitor and neprilysin inhibitor are not commonly given together because of excess risk of angioedema, because of this excess bradykinin effect. Here that's why ARB is combined with the neprilysin inhibitor because of less bradykinin effect, because neprilysin inhibitor will causes increased BNP level, and also in ARB by decreasing the angiotensin 2 effect and aldosterone effect, that will cause decrease in the cardiac remodeling. So neprilysin inhibitor potentiates action of the endogenous vasopeptides that counter malabsorptive mechanisms in heart failure. So there is decreased humoral activation, decreased vascular tone, decreased cardiac fibrosis, and decreased sodium retention. So neprilysin inhibition leads to these effects. There is decreased vascular tone, decreased vascular fibrosis, hypertrophy, and so decreased sodium retention. So how to inhibit neprilysin heart failure? Neprilysin inhibition alone is ineffective due to angiotensin potentiation. So neprilysin inhibitor alone is not effective because that will increase the angiotensin effect, whereas neprilysin inhibitor and AC inhibitor, that is potentially dangerous due to angioedema, and that's why neprilysin inhibitor plus angiotensin receptor blockade is used, so that they can have less angiotensin potentiation as well as less chance of angioedema. So neprilysin inhibition is not used alone because angiotensin activity is enhanced, but AC inhibition also cannot be given because of risk of the angioedema due to bradykinin effect. But neprilysin inhibition and angiotensin receptor blockade is safe as well as more effective. So sacubitril valsartan, this combination you should remember. Ivabradine acts by inhibiting the IF channel, that is a funny current present in the cardiac AC node. They reduce the persistently elevated heart rate and evaluated as treatment of the heart failure with reduced ejection fraction who have a resting heart rate of at least 70 beats per minute. So heart rate reduction is another approach of treating the heart failure. When we have used all the drugs like ivabradine, like beta blocker, AC inhibitor, spironolactone, neprilysin inhibitor, but still it is not successful, then if patient's heart rate is above 70, then we can try with ivabradine. That will cause decreased heart rate, and that will causes decreased oxygen demand of the heart. Next group of drugs, vasodilators. So AC inhibitor we have discussed as vasodilator. Neprilysin inhibitor is also vasodilator. First, there are some other vasodilator which will increase the nitric oxide effect. Nitric oxide itself gets converted to intermediate reactive nitrosothiol, which increases the cyclic GMP effect. So what are the drugs? We can use nitroglycerin. I have discussed in ischemic heart disease class. So nitroglycerin in patients of heart failure dyspnea, it is a vasodilator. They reduce the filling pressure and ultimately the pulmonary congestion. But adverse effect is headache, flushing of the face, and remember sildenafil and other vasodilator potentiate the hypertensive effect of the nitrate should not be given together or within 24 hours of the therapy. Arterial dilator hydralazine. So hydralazine and nitrate is often commonly combined because one is arterial dilator and nitrate is vasodilator. So vasodilation due to hydralazine is partly endothelium dependent and may involve generation of the nitric oxide in stimulation of the CGMP, increasing the intracellular level of the CGMP associated with vascular smooth muscle relaxation. Sympathomimetics. So we have discussed cardiac glycoside is inotropic agent, and when cardiac output is significantly low, then we can promote the increase the cardiac output by some sympathomimetic agents. So they improve the cardiac performance through positive inotropic effect. So they are used in acute setting only. That lead to increase in the intracellular calcium CMP. That results in activation of the protein kinase, and slow calcium channels are often then phosphorylated by protein kinase, which increases the calcium flow so into the myocardial cell, causing increased force of contraction of heart muscle. So remember, they are the positive inotropic drug, and they promote the excess cardiac contractility and try to improve the peripheral perfusion. Dopamine we can use. So dobutamine has more selective inotropic than chronotropic effect without any significant change in the peripheral resistance and BP. So dobutamine heart rate is not significantly improved. They will increase the mainly contractility. That's why dobutamine is preferred over dopamine here. Dopamine increases the heart rate as well as increases the contractility, but heart rate increase is not beneficial in that setting. And dopamine, you have read it already in a autonomic nervous system. It has 3 dose range, but in therapeutic dose is 5 to 10 microgram per kg per minute. It stimulates beta 1 receptor, resulting in increase in the cardiac output, but the total peripheral resistance is unchanged. So remember, dobutamine, dopamine, the sympathomimetic, they are increase the cardiac output and to be used in acute setting when ejection fraction is significantly low. But dobutamine is preferred here. Next group of drug is inodilators. So these are vasodilator as well as positive inotropic effect. These are called inodilator. They are actually phosphodiesterase 3 inhibitor, inamridone, milrinone. They inhibit the enzyme phosphodiesterase 3 and increases the cyclic AMP concentration within the myocardial cell, and there is a result. As a result, there is sustained rise in calcium concentration in this cell that cause increased cardiac contractility. So, due to this increased cyclic AMP level, there is calcium level is increased and contractility is increased. Also, increased cyclic AMP also leads to vasodilation. So they are inodilators. That means inotropic agent plus vasodilator because they increase the cardiac contractility and at the same time produce vasodilation. Thrombocytopenia is the most prominent dose-related adverse effect. So remember this name, inamridone, milrinone. So in heart failure, they are very preferred drug because of their inotropic effect as well as vasodilatory effect. Now next few non-pharmacological measures. We need to reduce the sodium significantly. It is 2 to 3 gram daily. So sodium chloride actually. So salt restriction is must for successful therapy of the heart failure. So otherwise there is again salt and water accumulation in the body, and the sodium chloride intake should be less than 3 gram per day, whereas in hypertension it is less than 6 gram per day, but in heart failure limit is further lower. So it is less than 3 gram per day, and fluid restriction is needed if there is hyponatremia, but we have to use calorie supplementation. Often heart failure patients having weight loss, smoking cessation, alcohol cessation, and also less intake of the caffeine is advised. Activity routine modest exercise for class 1 to 3. For you volume class 1 to 3, I shall discuss what is the classes of the heart failure, and isotonic exercise such as walking, riding on stationary bicycle ergometer is needed. Now treatment algorithm. Before that, I shall discuss the stages of the heart failure. There is a Newark Heart Association scale, NYHA 1, 2, 3, 4. So that is very easy to remember, and that is actually helping to decide which therapy to give on which patients. So NYHA 1 means patients having structural heart disease, but patient is feeling symptom only when he is doing more than normal activity. That's why it is often detected late. So when we are doing more than normal activity, often we are having some respiratory distress, but often patient ignores that. So if already patient is having some structural heart disease, then then that is called NYHA class 1. NYHA class 2 means feeling symptoms or respiratory distress at normal activity. NYHA 3 means feeling symptom at less than normal activity, that means walking a few meters can cause respiratory distress, that is stage 3. And stage 4 is dyspnea or respiratory distress even at rest, so that is stage 4. So dyspnea at more than normal activity is stage 1, dyspnea at normal activity is stage 2, dyspnea at less than normal activity is stage 3, and dyspnea at rest is stage 4. So stage 4 is the acute situation when heart cardiac output is significantly low, where perfusion is low. So in stage 4 we have to avoid the beta blocker, and in stage 1 is often undetected, but if it is detected then we can manage it with ACE inhibitor and diuretics. Stage 2 and 3 we can give the ACE inhibitor, diuretics as well as beta blocker to be given, because beta blocker is, by prevention of remodeling, it will increase the survival of the patient. Stage 3 normally ejection fraction is further low, there ACE inhibitor, diuretics, beta blockers, plus we can add spironolactone, and also we can add neprilysin inhibitor inhibition like sacubitril. Remember, ACE inhibitor and sacubitril is not commonly given, so rather we use ARB plus sacubitril because of less risk of development of the angioedema. And in stage 4 all the drugs are given, but remember beta blocker have to be avoided in stage 4. Rather we use some positive inotropic drug, like you can use inodilator, you can use dopamine, or you can use dioxin for sometimes. And treatment algorithm, this is the treatment algorithm. Remember, patients with symptomatic heart failure with reduced ejection fraction, so HF-REF, that's treatment we have to know, because HF-PEF has no successful treatment yet. We can try this therapy in HF-PEF also, but HF-REF, there is a satisfactory treatment is there. The therapy with ACE inhibitor and beta blocker uprated to maximum tolerated evidence to the dose base. So remember, ACE inhibitor, ARB, beta blockers, all we have to use in heart failure in very low dose, because ejection, though these are already antihypertensive drugs. So ACE inhibitor, ARB, beta blocker will all reduce the blood pressure of the patient, but in heart failure commonly patient's blood pressure is low because cardiac output is low, that's why patients are having hypotensive commonly, but still we have to use them for better prevention of the remodeling action. That's why beta blocker ACE inhibitor should be used in very low dose, and dose should be gradually increased if patient can tolerate. And still symptomatic and left ventricular ejection fraction less than 35%, then at MR. MR is mineralocorticoid receptor antagonist, or that is the aldosterone receptor antagonist, spironolactone. If still is patient is symptomatic and left ventricular ejection fraction less than 35%, then ARNI is replaced by ACE inhibitor. ARNI is, that is sacubitril valsartan combination, that means angiotensin receptor neprilysin inhibitor, that is called ARNI. So sacubitril is neprilysin inhibitor, and ARB we use vasodilator. So both of this combination is to get called ARNI. So if patient is symptomatic even after adding spironolactone, beta blocker, ACE inhibitor, then switch over to ARNI. And if patient's sinus rhythm is and heart rate is more 70 per minute, then we can use beta ivabradine. But if it is QRS duration is more 130 millisecond, that then we have to use a special device therapy, that is called CRT, cardiac resynchronization therapy. And if it's resistance symptom, then we can use, consider dioxin or HISDN, that is the hydrolyzine isosorbide dinitrate. And so this is this treatment algorithm. So we have to use diuretic first. So look here, diuretics to reduce symptom control, and if symptom is controlled by diuretics, then we add gradually ACE inhibitor and or ARB plus beta blocker in low dose. Gradually dose is increased if patient can tolerate. Then add spironolactone if patient is still symptomatic and if ejection fraction is less than 35%. Then add ivabradine or neprilysin inhibitor plus ARB, and if patient is still symptomatic, then add dioxin. So dioxin is the last day of therapy, though it is need to be read more in the heart failure chapter. So this is the treatment algorithm. And heart failure with preserved ejection fraction, commonly you have to treat the cause. It can be due to atrial fibrillation, it can be due to obesity, hypertension, diabetes mellitus, renal failure, coronary artery disease. So treatment of HFpEF, it is recommended to screen the patients for HFpEF or moderately reduced ejection fraction for cardiovascular and non-cardiovascular comorbidities, which should be treated first. So treatment of the cause actually is helpful in the treatment of the HFpEF. Now this was the treatment of the chronic heart failure, and now there is a acute heart failure. So acute heart failure therapy, we have to relieve the congestion. I am not going into detail, and relieve the congestion as well as increase the cardiac output. So often there is significant decrease in the cardiac output, and we have to use inotropic drugs. And if peripheral perfusion is significantly less, we can sometimes use IV fluid. But if patient is having very congestive symptoms, then we have to use diuretics. So patients are of acute heart failure difficult to manage because they have hypotension as well as congestion. So diuretics plus we have to use diuretics, but that will also cause further reduction in the BP, and that's why treatment is difficult. Okay, so this can be divided into four variety: dry, warm, dry, wet, wet, warm, and wet, wet. Dry, warm, dry, cold, wet, warm, and wet, cold. Depending on the warm and cold means what temperature of the patient. Warm means there is adequate perfusion. Cold means there is less perfusion. And wet and dry means whether presence of congestion or not. So depending on this congestion features, depending on the blood pressure, peripheral perfusion, we have to adjust diuretic therapy, inotropic therapy, as well as fluid therapy. Few not to do. So thiazolidine say we have not ready yet anti-diabetic drug. They will tend to cause promote salt and water retention. That's why it should be avoided. NSAID must be avoided because NSAID and COX-2 inhibitors will cause salt and water retention, because NSAID by acting on the kidney they cause decrease in the GFR, and that will promote the salt and water retention that is aggravated by the heart failure. So it must be avoided. And dilitiazem and verapamil calcium channel blockers are avoided because they will cause decrease in the cardiac output further. So dioxin, though beta blocker is used, but calcium channel blockers are not used because though both are decreasing the heart rate, but beta blocker is used mainly for its extra cardiac effect, that is the renin, angiotensin, aldosterone is blocked, and that's why beta blocker prevents the remodeling. But calcium channel blocker cannot prevent remodeling, only they reduce the heart rate. That's why our cardiac output is also decreased. That's why calcium channel blocker like dilitiazem, verapamil should be avoided in the heart failure. And ARB, SC inhibitor, remember they should not be used together because of risk of hyperkalemia. And also remember SC inhibitor and neprilysin inhibitor should not be used together because of risk of the angioedema. So heart failure, this is the treatment, this is the conclusion. Optimal utilization of the available drugs, general measures, and surgical procedures appropriate to the conditions improves the outcome of the patient. And early identification of risk factors is important, and also staging is important to decide which drug to give in which patients.